In the name of Allah, the entirely merciful, the especially merciful. Let's solidify two fundamental concepts, osmolality and osmotic pressure. They are two sides of the same coin, describing the power of a solution to draw water across a membrane. First, osmolality is the measurement. It tells us the total concentration of all dissolved particles, or osmoles, a kilogram of solvent, which in our bodies, is water. Its unit is milliosmoles per kilogram, or mosm/kg. It's a property of the solution itself. Osmotic pressure, on the other hand, is the force. It is the physical pressure that would need to be applied to prevent water from moving into that solution as a semi-permeable membrane. It's the practical consequence of osmolality. Its unit is millimeters of mercury, or mmHg. The relationship is direct: the higher the osmolality, the higher the osmotic pressure. We can see this clearly in the previous table. The total osmolality of plasma is about 301 mosm/kg. When we apply the conversion factor and correct for non-ideal behavior, this translates to a massive osmotic pressure of about 5,440 mm of mercury. This immense force is why maintaining osmotic balance is so critical. Even a small osmolality between compartments, for example, caused by a low albumin level reducing the oncotic pressure, can lead to significant fluid shifts, causing edema or dehydration at the cellular level. In short, osmolality is the concentration, and osmotic pressure is the pulling force that results from it. Let's solidify two fundamental concepts, osmolality and osmotic pressure. They are two sides of the same coin, describing the power of a solution to draw water across a membrane. First, osmolality is the measurement. It tells us the total concentration of all dissolved particles, or osmoles, a kilogram of solvent, which in our bodies, is water. Its unit is milliosmoles per kilogram, or mosm/kg. It's a property of the solution itself. Osmotic pressure, on the other hand, is the force. It is the physical pressure that would need to be applied to prevent water from moving into that solution as a semi-permeable membrane. It's the practical consequence of osmolality. Its unit is millimeters of mercury, or mmHg. The relationship is direct: the higher the osmolality, the higher the osmotic pressure. We can see this clearly in the previous table. The total osmolality of plasma is about 301 mosm/kg. When we apply the conversion factor and correct for non-ideal behavior, this translates to a massive osmotic pressure of about 5,440 mm of mercury. This immense force is why maintaining osmotic balance is so critical. Even a small osmolality between compartments, for example, caused by a low albumin level reducing the oncotic pressure, can lead to significant fluid shifts, causing edema or dehydration at the cellular level. In short, osmolality is the concentration, and osmotic pressure is the pulling force that results from it. This slide defines two key concepts, osmolality and osmolarity. While they are often used interchangeably in clinical medicine, there is a technical difference. Osmolality, spelled with an L, is the measure of osmoles of solute per kilogram of solvent. Its unit is osmol per kg. Osmolarity, spelled with an R, is the number of osmoles of solute per liter of solution. Its unit is osmol per liter. The good news is that for clinical purposes in aqueous solutions like plasma, the difference is negligible. As the slide states, 1 liter of plasma is approximately equivalent to 1 gram of plasma. Therefore, in practice, plasma osmolarity and plasma osmolality are considered equal. This is the foundation for understanding how solutes, including albumin, contribute to the osmotic forces in our blood. Now, let's look at the practical formulas we use every day. The standard calculated plasma osmolarity is given by this equation: 2 times the sodium, plus glucose over 18, plus BUN over 2.8. This typically gives us a normal value of about 285 milliosmoles per liter. Why these divisors? They simply convert the glucose and BUN from their common units of mg per dl into mole per to match sodium's units. Now, for a total osmolality calculation, we must account for all solutes. This becomes critical in cases of intoxication, where we add the concentration of F divided by 3.7, or methanol, to the standard formula. But the most physiologically important concept is effective osmolality, also known as the tonicity. This calculates the osmolality of solutes that are trapped only in the extracellular compartment, ECC, and therefore can actually pull water across membrane. We do not include BUN, ethanol, or methanol in this calculation because these molecules diffuse freely into cells. Since they don't create a concentration gradient across the cell membrane, they don't cause water to shift and are ineffective osmoles. This is why a patient with high BUN or ethanol intoxication becomes dehydrated, their body water is evenly distributed. Our previous calculations assume that all ions in a solution behave as perfect, independent particles. However, in the real world of physiology, this isn't entirely accurate. Due to interionic attraction, the electromagnetic forces between positively and negatively charged ions do not behave entirely independently. They cluster slightly, which makes the solution act as if it has fewer effective particles than we initially calculated. We correct for this deviation from ideal behavior by using the osmotic coefficient. For plasma, this factor is approximately 0.93. This means that the osmotic pressure of a solution like plasma is about 93% of the theoretical pressure we would calculate by simply counting all the ions. It's a small but important factor that brings our theoretical models in line with observed physiological reality. This table provides a beautiful snapshot of the osmotic balance between our body's major fluid compartments, the plasma, the interstitial fluid, and inside our cells. The first and most important takeaway is right at the bottom. Despite having completely different chemical recipes, the total osmolarity of all three compartments is virtually identical, at about 301 milliosmoles per liter. Why is this so important? Because water moves freely across membranes to achieve osmotic equilibrium. If the osmolarity weren't balanced, water would rush into one compartment, causing cells to swell or shrink and ultimately die. This is the fundamental principle of fluid homeostasis. Now, let's look at how this balance is achieved with different ingredients. In the extracellular fluid, both plasma and interstitial, the dominant osmole is sodium. You can see sodium and its accompanying anion, chloride, make up the vast majority of osmolarity here. This is why serum sodium is the primary determinant of plasma osmolality. Inside the cell, the picture is completely different. The dominant osmole is potassium. The intracellular fluid has very little sodium, but a high concentration of potassium, along with other organic phosphate molecules like phosphocreatine and adenosine triphosphate. This stark difference, sodium outside, potassium inside, is maintained by the energy-consuming sodium-potassium pump in every cell membrane, and it's essential for nerve impulses and muscle function. You'll also notice a key difference between plasma and interstitial fluid, protein. Plasma has a much higher protein content, especially albumin. This creates the oncotic pressure difference that pulls fluid back into the capillaries, which is crucial for preventing edema. Finally, the table makes a critical correction. It lists a corrected osmolar activity of 281 mosm/L. This accounts for the osmotic coefficient, the fact that ions interact and don't behave as perfectly independent particles, slightly reducing the effective osmotic pressure. In conclusion, this table shows us that the body maintains a delicate and active balance. The constancy of total osmolarity protects our cells, while the starkly different compositions of each compartment are what allow life itself to function. Now, let's put numbers to these forces. The total plasma osmotic pressure, from all solutes, is massive, calculated to be about 5,440 mm of mercury. The interstitial fluid osmotic pressure is almost identical, at about 5,420 mm of mercury. As we'd expect, since small solutes easily equilibrate across the capillary wall. The crucial difference between these two nearly equal giant numbers is a mere 20 mm of mercury. This tiny difference is the oncotic pressure. What creates this vital difference? It's the disparity in large, indivisible molecules, primarily albumin. The slide notes that the albumin concentration in the interstitial tissue is only about 20% of that in plasma. It is this small gradient of large proteins, generating a force of just 20 mm of mercury, that is the primary force pulling water back into the capillaries, counteracting the hydrous pressure that pushes fluid out. It's a stunning example of a small, precise force maintaining our entire fluid balance. This slide provides the essential rules of thumb for calculating the osmolarity of a parenteral nutrition solution, which is crucial for determining the appropriate route of administration, either through a peripheral or a central vein. First, for the glucose solution, you multiply the grams of dextrose per liter by 5. For example, 100 grams of dextrose gives you 500 milliosmoles per liter. Second, for the protein solution, typically from amino acids, multiply the grams of protein per liter by 10. So, 30 grams of protein equals 300 milliosmoles per liter. And third, for the lipid solution, multiply the of lipid per liter by 1.5. For instance, 40 grams of lipid results in 60 milliosmoles per liter. To get the total osmolarity of a mixed TPN solution, you would simply calculate and sum the contributions from each of these three components. This allows you to ensure the final solution is safe tended vascular access. Thank you.